But in this particular patient, she did exactly all those things, and we had to rush in and do an early cataract procedure. But here we're taking out a whole wedge of thin tissue by using a large tree fine, dissecting, and then suturing the anterior aspect of the graft to the peripheral rim. And it looks terrible here when we put the first sutures in, and did I do something wrong here? But actually, the patient did very, very well. And this is the OCT showing imagination of the tissue at 1 week, and about a year later, sort of remodeled in the inside of the eye, and then she wound up having to have her cataract removed fairly early. You can see the narrow angle right here. What about pellucid marginal degeneration? Now, that sort of told you a story about different things that we can do on the eye. Now, what I found really amazing was patients with pellucid marginal degeneration would land up with penetrating keratoplasties. So this is a patient that I swiped the images off and that I inherited when I got to my post at East Grinstead. This person developed high drops, as you can see right here. And they decided to do an acute graft for high drops. And this is what the graft looked like. Now, that's really comical, isn't it? It doesn't make sense. It's not doing anything optically. It's patched the cornea, it's patched the pellucid, but the goals of getting vision back have not been accomplished. And when I measured the length of this, it was 21 millimeters. Well, that's megalocornea redefined. So, figure, why would we take out tissue, going back to the principles I outlined before? The center of the cornea and pellucid is fine. It's the peripheral stuff that's the problem. So why not just take the peripheral stuff out? So that's what we did. And what we did was, this is a diagram to illustrate this, drawn freehand on an iPad. So you take out a wedge. The cornea is marked, the area of thinning is marked in advance at the slit lamp. The patient is brought to the OR, and we've gone ahead and used a diamond knife and outlined a nice wedge. So you've got to be a bit like Zorro with a diamond knife and cut fairly good circles there. So we've done that. We removed the stroma. Now, the thing is, if you've got a big area of resection and you suture it, you're going to get stray right through the visual axis. So how are you going to avoid that? Well, you can learn something from our plastic surgery friends again. What do they do when they do facelifts? They undermine the tissue, right? And then they pull the face up and stitch it all up again. And why do they do that? So there's nothing holding everything up. Well, we can do the same thing on the eye, too. So we approach the eye, because it's easy to dissect, we approach the eye from the superior aspect, dissect the whole cornea off, and they can see that's the dissection plane right there, onto the wedge, and then we suture it up. Now there are no posterior striae, and we then inject an air bubble to push the posterior lamellae back up again, and that's it, the job's done. And this is a patient, and this looks like a very oval cornea, but that's okay. They have about 17 diopters against the rule, and then after surgery, they got about 17 diopters with the rule, and that's exactly where we want them to be, double the amount, because it will just regress over time. And so that's one. This is a video showing the procedure. So here I am, slightly speeded up, doing the wedge. You can see the cornea's been outlined very well there, preoperatively. I'm using the same diamond to make an incision. Here I'm going to inject air into the anterior chamber, and what I'm doing is using Melis's technique of identifying how deep I am as I'm dissecting. So the air goes into the anterior chamber. I've taken that wedge off. There we go. And I thought I'd better start the dissection here. What I was hoping was I'd be able to just do a bit of dissection and close it off. But I realized I couldn't, so I decided to do what I usually do, which is to dissect the whole cornea off. So that's a quadruple speed. Not that rough. And here I've dissected this cornea off completely now. So here we go. We suture up the wedge. And the job there is accomplished. So this is what a sample cornea looked like. Again, we published this in Cornea, available for you to take a look at in terms of technique and outcomes. And this is the patient at 3 months following surgery with very little astigmatism. And looking at best corrected visual acuity, this is pre-op and this is post-op. you can see that all patients were 20/40 or better, certainly best corrected after surgery. So we accomplished our goal of giving them better vision and actually good, best spectacle correct vision. They didn't have to get into contact lenses, which is really hard to fit in this situation. Now, this is a patient from Afghanistan who came to see me. And he was sent to me by another surgeon who said, you know, I know you do this wedge resection, but I bet you can't do one on this patient. And I took one look and said, yeah, you're right, I can't. This patient's got high drops over here, it was resolving, but it extended 6 clock hours. I thought, yeah, I'm actually not bad with a diamond knife, but 6 clock hours, I'm not sure I can really do that. So I decided to use a femtosecond laser. And we used the 2 arcs, we sort of fudged it with the laser to tell the laser we were doing 2 limbo-relaxing incisions. The good thing about this laser is that it uses OCT. I know exactly what depth I'm going to when I'm making these cuts. So we made the more central cut first and then did the peripheral cut. And that I didn't expect wonders from, but I wasn't really bothered because it's out in the periphery. But also very conscious of this high drops in this area over here. So that's fairly well demarcated. So I had 2 tram lines. So what I'm going to do with the top to avoid dog ears, all I needed to do was extend the wounds this way to a V, and then I could put the cornea together. So now the tricky bit is, this is a fairly thin cornea in the periphery, and I could dissect it all without perforating. And I know that's, you can see I'm avoiding that area on purpose because I know that's just recently perforated. And I'll leave that right to the very end. I just need to make sure I've got my dissection. Now I'm pulling that off, and as I say, this is speeded up, so I'm not making that rough. So here, using a pair of Van Eyck scissors, and because it's so thin, it really does peel off Descemet's membrane, and the lamellar surgeons in the audience will tell you that. So I just want to make sure this was not, the laser didn't do a very good job here, just kind of scored the cornea. So I'm using these scissors to finish off what the laser should have done. And now I've got it, yeah, gingerly, you see the chamber just shadowed a little bit there, and that's it. So the chamber shadowed, but I'm particularly bothered because that is going to be invaginated into the anterior chamber once I'm done. And then we go ahead and suture that. Now it's kind of difficult. There's a lot of space there to close, but it can be done. And again, here I'm using merciless suture. That looks terrible, doesn't it? Oh, the stray everywhere. But I know I've dissected that cornea off, and you'll see in a moment that you know, this patient does very, very well. Once I'm done, so that's it, I'm done. There's an air bubble in the interface. I'm not too bothered about that. It'll get absorbed. And now I'm just burying these merciless sutures, which I have no intention of removing unless they decide to protrude from the surface. And that's it. And this is the patient. This is the patient preoperative, just to remind you. And this is what they look like postoperatively. What really alarmed me was this area here. This is probably about 6 months later. And I realized that area is still very elastic. So what I did was cross-link him. And he was changing, his thickness was changing. So I cross-linked the whole cornea, and he stabilized out. And his vision now, best corrected, is 20/30, doesn't need contact lenses. And this is the difference map showing the change that we managed to accomplish pre-op to post-op. You can see there's quite a lot of depression here on the topography, showing a huge magnitude of change. So corneal crescents and patches and wedges, and they're very useful in therapeutic situations for peripheral melts and perforations. You can use them tectonically, use them to patch an eye, you can use them in terions, murans, rheumatoid melts, and infected corneal perforations. And you can also use these similar techniques to alter corneal shape, but you need to do this with a bit of caution and good forward planning. So we are actually doing corneal plastic surgery, and it's really a sophisticated application of lamellar grafting techniques, and the applications are phenomenal, and more people coming with other ways of skinning the same cat. Thank you for your attention. you have any questions?
Yeah,
Samara.
thank you. Thank you, Dr. Dan. So, is there any questions? Yeah, Dr. Nawilati?
So somebody here has got a question?
Yeah.
That's okay. We all have our problems. Why didn't I just what? Yeah. It's amazing, isn't it? We do LASIK and there's no scarring either. Well, firstly, we're going very deep in the cornea, and the lamellar tissue is not packed as densely, so you're less likely to scar. It's also it's host tissue, and host tissue, host to host, seems to do just fine when it's stroma to stroma, as opposed to cutting through dermis or cutting through Bowman's layer. When you do that, so if you cut through dermis and skin, you get a scar. The eye is derived from the skin, as you know. You cut through Bowman's layer, and you get a scar too. But when you're within the lamellar tissue, you don't get scarring. They may get haze for a short while, and then it clears. And they do very, very well. Well, I mean, so if I understand this, you're talking about pediatrics, but pediatrics, what age group? You're not talking about 5-year-olds, you're talking about prepubertal and pubertal, right? Under the age of 18. Well, I think that in this day and age, we should be able to pick up patients who have keratoconus early enough and cross-link them and arrest the progression of keratoconus. I don't think you could take somebody who's got very advanced keratoconus with maybe a central apex of 70 diopters and a thin cornea and consider doing cross-linking on them, because you might wind up damaging the endothelial cells, right? So you probably would, if you had to do a graft, do a lamellar graft on those patients, and if you're worried about peripheral thinning, as we can see happens, then do cross-linking on the rim afterwards. Well, that's what I do. You know, and in any keratoconus patient who's young, I do the lamellar graft, and if I get any hint, and I do annual topographies on these patients and do a subtraction map. If there's any change after the sutures are out suggesting peripheral ectasia, I just take the peripheral rim, take the epithelium off, impregnate it with riboflavin, and cross-link them. And that seems to arrest the progression of disease. But you can do lamellar grafts in high drops too. So, I mean, if you can preserve endothelium, why not do it? I would not. I have to say, again, we published in the BJO on, I think it was 12 cases of deep anterior lamellar keratoplasty on high drops, and the visual outcomes are superb in those patients. There's no reason not to do it. So again, I would do a high drops patient if the scar was central. Well, when we've had this, when the scar was central, instead of doing the conventional 6 and 12 cardinal sutures, I just sutured them up superiorly, and I let the air out of the anterior chamber and pushed the posterior lamella inferiorly, so the scar was out of the visual axis, and then sutured them up, and that worked. So there are tricks you can use, but so I would avoid doing a PK in those patients, certainly not acutely either. But in the interaction section, I'll be showing you how high drops can be taken care of now in the acute setting. But if you're worried about the peripheral rim, there's no hurry to cross-link them before surgery. You can do it after surgery, after you've done the graft.
There is a rule now of mosaic cross-linking, the customized one, the mosaic or the customized cross-linking. Yeah. So I think it's very important to be done to patients who have very large ectatic cornea from the beginning, where we can just do multiple treatment with different energy setting, and then we can subject the focus on the area of maximum thinning. And because it's not anymore like 7 or 8 millimeter, we can go even up to 9 or 11. So I think that's another way.
Just be careful.
And we can do also wedges also. With that
and that's great. The technology is available, and
we have it here. We just got a machine.
Yeah, I don't have access to it, and but it probably won't change what I do anyway, because I'm not sure which area is going to become ectatic and which is not. I'd rather get the graft on than deal with that later on. The one thing to be aware of, though, is I don't know if you cover the limbus, but there's a great study by Tara Moore and colleagues where she looked at the DNA on patients who'd had cross-linking at the limbus, and it was the changes were similar to anybody who's at risk of having a neoplasm.
Yeah.
So if you're going out to that level of periphery, in fact, any cross-linking, you probably should cover up the limbus.
Yeah, with the shield, at least 1 millimeter.
Or a Chiat sponge or something, just to avoid the irradiation of the ultraviolet light. Because it's a combination of both the irradiation and the riboflavin. You're getting a double whammy right at the limbus, where you don't even need it in that direction, so might as well cover it.
Correct, yeah.
Yeah, when I read that paper, I got really alarmed and worried about my patients developing squamous cell carcinomas in time to come.
Yeah.
That would not be good.
Exactly. The other thing is that I noticed that you used the periosteum and the pericranium. What about pericardial patches? Would it work, or it's too thin or not?
Tutoplast, yeah, that's good.
Tutoplast, yeah.
It's good, but it's not vascularized.
Okay.
So it's been stored in it's either freeze dried or it's been stored in something. Yeah. And yes, it's tough. It's resistant to collagenases for a while, and you might be able to buy yourself some time for tissue to grow across. But there's nothing like having good, strong vascularized tissue. Okay. And I think you don't have to worry about those patients because they do vascularize extremely fast, and it's self tissue too. So it's theoretically safer, and that's not too difficult to do either.
Yeah, not at all.
I'll tell you, I can teach you the technique. As long as you have general anesthetic, it's not difficult. But useful to have in your armamentarium.
Yeah.
Mm. Yeah. Sometimes not. If it's an old graft, and some of those were, if you calculated the age of the donor and how long they'd been in the host, they were over 100 years old. But the endothelial cell counts, anyway, you can see they were all less than 1,000, and they survived. But when you've got an old cornea, it's actually quite easy to take the stroma off sometimes if you've got the right plane. I don't really like doing that because then it's a very thin thin posterior portion, and that could perforate very easily. So imagine having a decimase membrane or pre-decimase Duas layer attached to the peripheral rim. It doesn't take much for that to tear apart, and then I'm doing a DMEC on a DLK rather than a DLK on an old PK. So I've had several where it's just peeled off on its own, and I've had to be very careful about how I've sutured that back on again. But yeah, but as long as you're deep, it doesn't really matter. They get good visual outcomes. I'd rather do that than do a large full thickness graft where they put them at risk of rejection in the long term. It's a question in the back. Again, I do very large lamellar grafts on those patients. I peel off what I can, and it's very, very difficult not to perforate in keratoglobus globus. But because you're actually shortening tissue, so a lot of keratoglobus globus patients that I've had, they got corneas with diameters of 17 millimeters. Well, I can't get tissue big enough to accommodate that. So what I do is I cut out 10.5, 11, and then I just bring in the tissue, bring in the limbus to the graft, and that makes the cornea a lot smaller. So all the perforations that happen are sort of self-sealed because you got tissue crammed against the cornea with air inside, and it seems to work okay. But I've not had to do a full thickness graft on a keratoglobus globus yet. All the ones I've done have been lamellar grafts. Yes. Mm-hmm. It's possible, I suppose. I don't know. But my experience with epikeratofacial has not been brilliant. With freeze-dried epikeratofacial, I've had to take them out. With sort of live epikeratofacial, where the tissue is cryoed and then reformed and then put directly on the eye, and it's donor bank tissue as opposed to freeze-dried tissue, that seems to do a lot better. But again, what you're doing is, if you're following the principles of keeping shape and keeping clarity, and I think there's a lot you can do in manipulating that cornea so that you enable it to see. There's more coming. There's a lot more tissue now becoming available that will help us do all these sorts of things with different companies making inlays and onlays and so on. There's a resurgence of interest in this area. And I think with newer cutting methods and using the excimer laser as opposed to a cryolathe, all those techniques are helping us get very, very smooth surfaces so we don't have interface hazes and epithelialization problems too. Hope that answers your question. Yeah. But you know, an onlay, you can do an onlay. If you dissect the limbus and you do a peripheral dissection of the limbus, preserving the limbal stem cells, you can do an onlay, 10 millimeter graft or 11 millimeter graft, or even put the sclera in too, and just tuck in the graft, bring everything together. As long as the central area is fairly clear, you're pretty much okay. You've taken those corneas that are really steep and you've flattened them and you've given them a more normal surface, and you've also beefed up the cornea. So if they get any traumatic injuries, they can perforate. Well, you're protecting them there too. So that's another technique you could use. There are some people who just take the epithelium off and just plaster one of these things on and hope for the best. And that's not a bad technique either. And what some have done is done exactly what I've just said. If they don't see well, they've done a DALK within that graft. So they've gone deep, and then because there's only 8 millimeters that they're looking at, they've peeled off the rest of the cornea under some control. It's easier to peel off tissue on 8 millimeters than out to 14 millimeters. And they've gone and done that and put a graft on, and they've done fine. So I think the important thing is to get them tectonically stable, and sometimes to your surprise, they actually see quite well when you do that. We'd like to try and be perfect at what we do. And we as surgeons often take a standard and bring it across without taking into consideration what we're trying to achieve. So the standard is when you do a deep anterior lamellar for a regular keratoconus patient, you want to get deep, you want to get smooth, and so on. Well, you try and do the same thing with a keratoglobus, you're going to have a big problem. You're putting that patient at risk of having a major perforation and a major large graft. Well, you can forget, you don't have to do that. You can do it in 2 stages. And I think we sometimes have to rethink how we approach patients. And I always look at it from the point of view is, what's the worst thing that could happen? And can I avoid it? And if I can, that's the route I take. And if it means a second operation, fine, do the second operation. I haven't had to yet. Any other questions?
Yeah, $1 million question about Ehlers-Danlos.
About Ehlers-Danlos?
Oh, yes.
What do you do?
Don't do. Just we put glues. That's the only thing we can do. We're just gluing them. We try to suture to avoid she's wearing.
There are different forms as well of Ehlers-Danlos. It depends how bad they are. I mean, I haven't seen too many.
The brittle one with a very thin sclera.
Yeah.
This is the one that we have here.
You have, yeah. Those are scleral lenses are good on those patients. They're protective, and they give them vision too. And also they act like a buttress, so they stop them from getting further, more ectasia. So if you've identified an Ehlers-Danlos early, get them as scleral lenses, big sclerals as early as possible. They'll get used to them, and it'll probably delay progression in those patients too. But yeah, that's a tough condition, especially the variety you've described. Great. Well, thank you. I hope that was entertaining enough. Yeah. Yeah. Yeah, I'm going to talk about that tomorrow. They do. We've done this twice now. They disappear. So I think, when am I giving that talk? Is it tomorrow? Is it tomorrow morning? Is it? So I'm giving that. I'm talking about all limbal stem cell transplant, the whole gamut, and I'll be mentioning this as well. We're discussing this further tomorrow with the PCR analysis and everything else.
Okay.
So great. Well, thank you very much.
This is the last question. So we'll be back at 3:30 for part 2, interactive cases.
you want. Yeah, it's great.
Right now, one talk with the technicians.
Sure. Okay. Oh, good. Okay. Good.